Hello, welcome to everyone. This is the National Center on Advancing Person-Centered Practices and Systems May webinar. And we're pleased to have an esteemed panel joining us to have a dialogue about linguistic competence as it relates to person-centered practices. So for those of you who are unfamiliar with the National Center on Advancing Person-Centered Practices and Systems, or NCCC, we are an initiative that is funded by the Administration for Community Living and the Centers for Medicare and Medicaid Services. And our mission is to make person-centered practices not just an aspiration, but a reality. And we do that through a number of ways, including providing technical assistance directly to states, hosting learning collaboratives and other events, and also hosting these monthly webinars. Next slide, please, Connor. We're glad that you're here, and we're really excited to be resuming this webinar series. We've been monthly strong for about a year, but did take a couple months off because of the COVID-19 crisis and knowing that so many folks were pulled in a lot of different directions responding to that crisis. But we've resumed that now, and we have some really exciting webinars coming up as well. All NCCC webinars are free and open to the public. Myself, Bevan Croft, and Alex Bernardi are co-directors of NCCC, and we're also joined by other members of the NCCC team who are working behind the scenes to put together this webinar. Next slide, please. As I mentioned, NCCC's goal is to promote person-centered principles. We do that in a number of different ways. We know that cultural competence, linguistic competence are critical aspects of person-centered practices, and you really can't be person-centered without being culturally competent, and those two things are not the same. And so we are hosting this four-part series in partnership with the Georgetown National Center for Cultural Competence to really highlight some of these dynamics, and that's what we'll be focused on today. I'll go through a couple of logistics, and then I'll turn things over to Alex to introduce the speakers. I'm seeing lots of folks streaming in, and it's wonderful to see you all coming. It's nice to see your hellos in chat. Please do feel free to use chat to interact with us, with each other throughout this webinar, and also to ask questions throughout the webinar. Connor and Miso will also be pasting in some logistics periodically into chat. And in those logistics, you'll see a link to access a live caption for Spanish, which appears in a different window. And then there's also captioning in English that's available right in your Zoom platform if you click on the closed caption link at the bottom of the Zoom application. Towards the end of the webinar, we will have a little bit of time to respond to Q&A. We often get a lot of questions and more than we'll have time to respond to, but we will work to put together some written responses to the questions as we're able. So if we don't get to any of your questions today, we should be able to respond to them in a written format after the fact. There will be some polls coming up throughout the webinar, and at the very end, we'll leave a couple of minutes for some evaluation questions. So please do be prepared to interact during polling times. Next slide, please. If you have any questions, you can always reach us at our email address, nccaps@hsri.org. And just know that this webinar is being recorded. The PDF slides are available now in the link that you'll find in chat, but also they'll be available on the website, along with the recording and a number of other resources about 2 weeks after the webinar. And if you could go back one more slide before I turn things over to Alex to introduce the speakers, I want to let you know about a new page that we're putting together at NCCC with some resources specific to the COVID-19 pandemic that all of us are grappling with. The link is there, but you can just visit our homepage and get to the resources right from nccaps.acl.gov. We're putting together a number of things. It's a work in progress, so if you go now, you'll see a couple of resources, but we're going to be be adding quite a few more in the next week or two. We are producing a series of video shorts with some of our WISE community members, offering their thoughts on how we can sustain person-centered practices during a time of pandemic, and also get through the pandemic, using person-centered principles. We also are posting a number of different resources for person-centered planning during the pandemic, including examples of familiar person-centered planning tools that have been tailored specifically to use, to support someone who's social distancing, to prepare in the event that somebody is hospitalized with COVID-19 and different things. So we're really excited to be offering those resources in partnership with some of our subject matter experts who really know a lot about this stuff. We also have posted some select resources around protecting your rights as a person with a disability during COVID-19. So all of those will be coming soon. And if you want the most up-to-date resources and notifications about that, please do follow us on Facebook. You can search for the National Center on Advancing Person-Centered Practices and Systems on Facebook. Follow us, like us, and as soon as anything is available, we'll be posting that. And we're also posting a number of other resources that are relevant to person-centered practices, both COVID specific, but also general on Facebook. So please do take a look and follow us there if you use that platform. Okay, so that's enough from me. I'll turn things over to Alex to introduce the speakers.
Thank you, Bevan. We have one poll or question, which I think we were going to bring up at this point to have people answer our poll. I see all of the people who are introducing themselves in the chat. And right now, just as another way for those who are in joining this webinar, if you could respond to this poll to describe who's here. This is a helpful way for the speakers to know who is joining us, and then I'll be moving on to introduce our speakers. So we'll leave the poll open for another few seconds. Please go ahead and indicate how you self-identify, and then I think we can close the poll and we'll take a quick look to see who's joined us. So we have a pretty even split between people who describe themselves as social workers, counselors, or care managers, and government employees. And then additionally, people who are participating in the role as community or faith-based service provider, organization employees, researcher analysts, and I think I need to scroll down to see the bottom there. We do have some who identify as self-advocates. Well, thank you. Thank you for everyone for participating, and thank you for continuing to add in your responses and to add your comments. With that, I want to quickly move to the introduction of our speakers. We're delighted to have joining us 4 people who are all going to present today. And in the order of the presentation, I'm going to go through quickly and introduce them. Tawara Good is the director of the Georgetown University Center for Excellence in Developmental Disabilities, and she's also the director of the National Center for Cultural Competence, with a mission to increase the capacity of healthcare and mental health care programs to design, implement, and evaluate culturally and linguistically competent service delivery systems to address growing diversity, persistent disparities, and to promote health and mental health equity. Next, we have Octavio Martinez, who is Executive Director of the Hogg Foundation for Mental Health and Senior Associate Vice President within the Division of Diversity and Community Engagement at the University of Texas at Austin. Additionally, he's a professor of psychiatry at the Dell Medical School and clinical professor at the Steve Hicks School of Social Work. Dr. Yanira Cruz is the president and CEO of the National Hispanic Council on Aging. She focuses on providing the Latino perspective on public health, older adults, and caregiver issues to increase policymaker and public understanding of the needs impacting vulnerable sectors in our society and to encourage the adoption of programs and policies that equitably serve everyone. And we're joined by Matthew McCullough, a Filipino-American with developmental disabilities, and he's currently the director for the District of Columbia Office of Disability Rights, the Americans with Disabilities Act Compliance Office for the district government. Mr. McCullough is recognized for his communications and training expertise in education, healthcare, diversity and sensitivity, cultural competency, and disability issues. We feel tremendously privileged to have all of you joining us here. And with that, I would like to turn it over to Tawara to take it away.
Thank you. I'm very excited to be here today and to get a chance to see so many people from my basement in my home. We spent time putting this panel together. We think that it will offer many perspectives and really rich information about linguistic competence. Next slide, please. So this afternoon, what we're going to do is take a deep dive, really looking at what linguistic competence is. We will look at foundational policies, the structures and practices, and we'll look at this within the context of mental health, healthcare, disability, and aging services. We will also offer perspectives from lived experience as it relates to linguistic competence. And I think it's really very important that we will look at the relationship between linguistic competence and person-centered practice. Next slide, please. These are our objectives. Again, we're going to differentiate linguistic competence from language access and implementation. Sometimes people confuse those. We'll cite legal mandates, requirements, and standards for language access and implementation. And we will examine these concepts and mandates, again, within the context of your respective roles and responsibilities. And we'll have an opportunity to do some additional polling. Next slide, please. Next slide, please. We're going to spend a little bit of time looking at the demographic trends across the United States. Next slide, please. I'd like to just share with you when we think about languages that are spoken in the US, and this is just data from the selected data from the largest metro areas. And so if you look, and anyone who's joining us from New York metro area, at least 192 languages are spoken at home. That, again, this is fairly significant. This is US Census data. In Washington, DC, there are 168 languages. We have languages estimated for Seattle, for Houston, and the Boston metropolitan area. And so as we look at the many languages that are spoken in the United States, and this is just looking at it by metro area, there are significant numbers of languages other than English and ASL spoken in the US. Next slide, please. And so as we look at the most recent data from the US Census, this is 2018, 2019 data won't be coming out until the summer generally. But we look at the percentages of people who speak only English at 78.1%, a language other than English, almost 22%. And then if we look at those in terms of categories, the percentages of people who speak Spanish, and sometimes it's referred to as Spanish or Spanish Creole, those that speak Indo-European languages. The census groups them all together in the smaller print. I tried to list the array of languages that would fall in that category. Then Asian and Pacific Island languages, and then other languages. I would dare say that this looks different in each state overall, but this is, again, looking at the national pattern as it relates to languages that are spoken in the US. Next slide, please. Many of you are familiar with the term limited English speaking households. It's a term that the census uses. It used to use the term linguistic isolation, but these are households where no one over age 14 speaks only English and also speaks the non-English language and English very well. that could be been said a little smoother. This is definitely language straight from the census. And so if we look at all households, it's 4.4% that was estimated in 2018. However, if you look again at the language groupings, that Asian and Pacific Island languages at 24.2% is larger than Spanish, which is the one we would typically think about. And so again, as you look at these data, I encourage you to like really think about what they look like in your local, in your state and local communities. Next slide, please. Should be a polling question. And this is, do you know the top 5 languages other than English spoken in your state or territory or your city or geographic locale? So is the poll coming up, or this is? Okay, this is a prompt question then, in terms of whether or not you know those top 5 languages in your state or territory, city or geographic locale. And again, this does not include, the data source does not include American Sign Language. Next slide, please. These again are languages spoken at home. There are many different data sources for this. So if you look to see what are the top 10 languages spoken in the US, you get a variety of different answers given the data source. And so the World Atlas lists the 10 that are there. The US Census Bureau has another set of 10, and then Statistica lists them. You would see some crossover among the languages. Again, this may look very different in your state, in your region, in your jurisdiction, and in tribal communities. Next slide, please. This is, again, data from the US Census, and it looks at the 12 primary languages spoken in the US, and the Spanish, Chinese, Vietnamese, Korean, Russian, Arabic, Tagalog, Polish, French, Haitian Creole, Portuguese, and Japanese. So again, many different sources for you to really explore these languages that are spoken in the US. Next slide, please. Had to really dig for this, but these are 10 of the largest Native American languages spoken in the US, and there's a listing there. While there aren't significant numbers who speak these native languages, I do think it's very important for us to take stock of that and to be familiar with them. Alaska, Arizona, New Mexico are home to half of the nation's native language speakers. And so again, very important data to share with you. Next slide, please. So with that said, we pretty much confirmed that there's a great degree of linguistic diversity in the US. We now are going to look at a definition and conceptual framework for linguistic competence. Next slide, please. These are our guiding values and principles for language access. And again, I encourage you to think about if your organization also has created such values and principles. We believe that services and supports are delivered in the preferred language and or mode of delivery of the population that's served, that written materials are translated, adapted, and provided in alternative formats based on the needs and preferences of the population served, and that interpretation and translation services comply with all relevant federal, state, and local mandates governing language access. And lastly, consumers, individuals, families are engaged in the evaluation of language access and other communication services to ensure quality and satisfaction. And I would say that as we look at all of the work that's been done in terms of language access, that this last bullet in terms of looking at evaluation of those services, that's something that we're lacking in overall. Next slide, please. So this is another polling question. So I'm just wondering, has it been converted to a polling question, or we're just gonna ask it of the group to consider.
It sounds like we could just do the polling right in chat if that's okay with everybody.
Okay, all right. So this question is to say, does your organization have a definition for linguistic competence? And the options are yes, no, I don't know, or it's in progress. And the next one is that values and or guiding principles for linguistic competence. Has your organization developed this? And again, it's yes, no, don't know, or in progress. So I will not be able to maybe check that. I'll ask your help to check on what people are responding, and we will be able to come back to that in terms of the polling question. Okay, and I'm encouraging people to keep putting that in, and we'll share with that. So if we think about this concept of linguistic competence, it is really defined in different ways in the literature. And I think that's important for us to look at. There, again, are many definitions that focus on language usage, and this is usually by linguists. The healthcare literature has the most frequent citations as it relates to linguistic competence. Some definitions, in fact most, combine cultural and linguistic competence into one definition. And again, adding linguistic to existing definitions of cultural competence is what we've typically seen. And that there are very few definitions of linguistic competence, including the capacity to address to communication interests and needs of people with disabilities in general. That's generally not what we see. And so if we look at the national CLAS standards from that advisory committee, we were really effective in helping them to think about the unique communication needs of individuals with disabilities. So next slide, please. These are definitions of linguistic competence in the literature. Those from Agency for Healthcare Research, the American Speech and Language Association, and again, from the national CLAS standards. That's there for your information and for your consideration, and there are links there for you to explore further. Next slide, please. So I'm now going to share with you a definition of linguistic competence that we use at the National Center for Cultural Competence. And a colleague of mine, Wendy Jones, came up with this a while back. We wanted our definition of linguistic competence to expand beyond simply interpretation and translation services for specific language groupings. And so that we look at linguistic competence as the capacity of organization and the people who work there, how they're able to communicate effectively to a diverse range of groups, anyone who may walk through the door. That may include people who have limited English proficiency. That may include people who have disabilities, individuals who may be deaf or hard of hearing. And it also includes individuals with limited English proficiency. So a broad range of folks would fall in this category. When we look at linguistic competence, at least from our framework, it means that organizations and providers have to be able to address the health literacy and mental health literacies of the populations that they serve. And lastly, very similar to cultural competence, there has to be policies in place, structures, there have to be procedures and practices, and importantly, there has to be resources dedicated to this capacity. So, you know, we just can't say it. We have to really look at the home for linguistic competence and what it will cost, both in dollars and also in personnel. Next slide, please. As we look at health literacy, this is so key and critical when we're thinking about person-centered systems and practice. And as we look at health literacy, it really requires a variety of things for people to be able to do. Those are all listed in the slide. This is from the work of Rima Rudd, who is thought of as, like, I'm just going to say, the queen of health literacy, has done astounding work at Harvard University. And so as we look at these things, it basically tells us it's a range of things that individuals are required to do. Next slide, please. However, as we look at health literacy, there's been some evolving concepts. So initially, I would say from the U.S. Department of Health and Human Services, emphasis had been placed on what the individual has to do. In fact, almost the entire onus was on individuals. However, there's new thinking about health literacy, and it really is shifting the responsibility from the individual to some extent to the capacity of professionals and health institutions to provide access to information and support the active engagement of people. That is really very different than from the perspective of individuals have to be able to obtain, process, and understand basic information. It's telling us that we have a lot to do as professionals to ensure that people understand and can access what it is that we're sharing with them in multiple modes. So I encourage you to think about, what does this mean for your own organization? Next slide, please. This is a definition of mental health literacy. And again, there are a number of these definitions. Just sharing that with you. Mental health literacy, again, has evolved over time. And we look at it as understanding how to obtain and maintain positive mental health, understanding mental disorders and treatments, decreasing stigma and related to mental disorders. So there's a range of things in terms of how people are not just talking about health literacy, but also looking at mental health literacy. Next slide, please. We also think about health literacy within the context of culture. This is from the U.S. Department of Health and Human Services, and that it really recognizes the role that culture plays in terms of health literacy. I'm not going to go through great details. It's really quite self-explanatory, and there is a link there for you to pursue additional information in this area. Next slide, please. So as you think about language access and implementation, we now are going to spend some time really looking at the legal mandates, guidance, or standards. How does your organization address these requirements? And what is the impact of such requirements on mental health, aging, and disability services? Next slide, please. I am sure that you're all familiar with the Civil Rights Act of 1964. The Civil Rights Act of 1964, specifically Section 601, gives us the basis to ensure for the concept of language access. I'm sure you've all heard the language, we can't discriminate against anyone because of their race or color or national origin. In this legislation, national origin really does speak to language and the languages that are indeed spoken. So we can't discriminate against someone because they happen to speak a language other than English. Next slide, please. And if we look at Title VI, the legislation, who does Title VI protect? And I think you have to enter one more click, please. We know that Title VI protects everyone. This legislation basically indicates that we protect everyone based on color, race, or national origin. And most importantly, Title VI protects against national origin discrimination and is not limited to US citizens. I'm going to say that again, that it protects against national origin discrimination, and it is not limited to US citizens. That is so key and critical. And I would say that many populations that are entitled to these language access services don't know that is indeed their right. Next slide, please. So these are slides just to help you, if you're unfamiliar with it, in terms of what providers must need to do to ensure language access. And again, it's pretty self-explanatory, and I just wanted to make sure that you had it, you had access to it, and you had links for additional information. Next slide, please. This is, again, another resource, is federal guidance regarding recipients of services that are funded through the federal government. And again, what the guidance is in terms of prohibition against national origin discrimination. It's an excellent website. and source. So I want you to have that for additional information. Next slide, please. As we think about people with disabilities, people who are aging, we look at people with mental health needs, that they may be receiving services from a range of government entities at the federal level. And each of these, the U.S. Department of Human Services, Department of Education, Department of Justice, and Department of Labor, all have their own language access plans and all of their requirements related to complying with Title VI. So again, I think that if you're receiving funding from that, or you're supporting people who receive funding from any of these areas in terms of services, that you should be aware of what it stipulates. Next slide, please. Another resource for you is the National Standards on Culturally and Linguistically Appropriate Services in Health and Healthcare. Again, these standards were created to look at both cultural competence and linguistic competence within healthcare settings. Again, a link is there, and there's a screenshot of a landing page for these standards. Next slide, please. These standards have one principal standard and then a total of 15 other standards that are categorized as you see there. Standards 5 through 8 specifically address communication and language, and they're quite helpful if they've not yet been implemented within your own setting. Next slide, please. So here's yet another polling question. And so this polling question is asking, has your organization developed the language assistance and implementation plan? And again, people typically call it a language access plan. And your responses are yes, no, I don't know, or if it's in progress. And while you're responding to that, perhaps Bevan can tell me from the previous polling question what kind of responses we saw.
Well, this is not a scientific analysis, I'm afraid, and part of it was difficult to see because it was, we saw a mix of two questions. But I'm going to say, what I'll say is that it looked like it was pretty evenly split between yes, no, and don't know
Okay.
For both questions. And we could do a little, we'll do a tally and see if we can come up with something a little more concrete after the fact.
Alrighty. So this one, when I am conducting training, I often ask audiences this question: do you know whether or not your organization has a language access plan? And many people don't know if they've had a language access plan. And for those people who said, yes, I know they have one, I ask, you know, what does it say? Have you read it? And again, many people are unaware of that, particularly, I'm going to say, in state government and other municipalities, especially if perhaps a language access plan is at a higher level of the organization. I suggest to you that you should find out about those plans, find out what the plan and what the responsibilities are as they've been described within your organization. And we know that any organization that's receiving federal funding to comply with Title VI, indeed, should have a language access plan in place. So again, I was interested in seeing the non-scientific version of the polling question. I'll have next slide, please. Again, this is just a process for looking at effective language access planning and implementation. And the data source for that is there. We look at understanding how individuals with limited English proficiency interact with your organization. It also looks at providing language assistance services, identifying and assessing LEP communities, training, providing notice of the language assistance services, monitoring and evaluating the services. And so these again are components of the plan for which you should be familiar. Next slide, please. So again, if we think about a language access plan, there are the policy directives. These are things that underpin to give meat and substance to what you're doing. It would be the plan itself, and then procedures. And so the link that's provided there will give you a great degree of detail in terms of creating a language access plan and the kinds of components that are in it. And I do suggest it for those who've not explored this in great detail to take a look at it. Next slide, please. So yet another polling question. So here we're asking, how familiar are you with your organization's language access implementation plan that is required by federal law? Are you very familiar with it? Are you somewhat familiar with this plan? Or are you not familiar at all? So again, please enter your comments in the chat box, and we'll be able to take a look at that later when we give follow-up to this group. And I see that the chat box is flashing, so thank you for responding. Next question, please. Next slide, please. So again, this is yet another polling question for your consideration. And this is really to look at how your organization or agency is addressing linguistic competence as I defined with you previously. So the options should be A, B, and C. And the first is that there's no staff training, no formal policies and procedures, nor dedicated budget. That would be response option A. Response option B, the second one, is that there are formal policies and procedures that are in place. Staff have received training, that the organization, agency, or practice provides interpretation and translation services routinely, and has adequate budget allotted for this capacity. So again, when you're engaging where you think your organization is, for A or for B. And lastly, for C, is that has a language assistance and implementation plan with which all staff are knowledgeable, that it complies with all aspects of Title VI. Staff speak languages of the populations and communities that they serve, and that there's a mechanism in place to evaluate the effectiveness of language access services as a component of quality improvement. So again, A, B, or C have a chance to rate where your organization is.
And Tawara, I'm looking at chat now and I'm seeing a majority of answers are A. There are a good number of B's and only a couple of people have answered C, or the last option to this question.
Okay, thank you so much. So you can keep them coming, and then we will move to the next slide, please. So as we think about the work of linguistic competence and specifically language access as defined by federal statute, we really can't ignore the isms and what their impact are on linguistic competence. We would not be doing our work. It's not as if the isms aren't alive and well in the United States of Columbia, United States of America, almost said District of Columbia, overall. And so we'll take the next slide, please. I created this slide. I want to say it had to be over 10 or 12 years ago when we were doing work with SAMHSA in terms of Substance Abuse and Mental Health Services Administration for systems of care for children and youth. And I am, I don't know, sad to say that it still has relevance today. And so if you look at the spiraling effect, in those circles are anti-immigrant climate, English-only laws, discrimination against people who have limited English proficiency, state anti-immigrant laws and initiatives, inadequate funding in health, human services, and education, a climate of fear and intimidation, and the lack of knowledge about Title VI. These are things that continue to thwart efforts for people to get the services that they need in the languages that they speak. And so and this are more contemplative questions. How is the social, political, and economic environment in your state affecting language access? And again, key and critical. In our work with our community of practice, we've heard that many families had stopped trying to seek services just for fear that they may be labeled unlawfully present just because they speak a language other than English. And also for you to think about how are these challenges addressed in your state or jurisdiction. Again, use chat feature to be able to describe that would be really very helpful, I'm sure, with Bevan and Alex as we think about continuing technical assistance and opportunities to really address linguistic competence to the fullest degree. Next slide, please. So this is a quick self-assessment. It's actually from one of the instruments, well, one of the tools that's on our website, and I just pulled out a couple. So this one you should be able to respond again in the chat feature. So, and again, this is looking at this from an individual level. When interacting with individuals and families who have limited English proficiency, I always keep in mind that, and your options are A, things that you frequently do, and it applies to you to a great degree. Another option is B, things you do occasionally, and that applies to you only to a moderate degree. And the last one is C, things I do rarely or never, or the statement applies to me at a minimal degree or not at all. So the first one is limitations in English are in no way a reflection of the person's level of intellectual functioning. And again, when interacting with individuals and families who have limited English, I keep this in mind. So that's one option. The next is their limited ability to speak the language of the dominant culture has no bearing on their ability to communicate effectively in their language of origin. How do you keep this in mind? And lastly, they may neither be literate in their language of origin nor in English. So I see some, I'm looking down and I see some all that came across. Keep your responses going in. You can also access this checklist on our website, and the information is there in terms of data source overall. You'd be able to find this. Thank you, keep coming in. And the next slide, please. This is my ending slide, and it's a quote from Nelson Mandela. And it's hard to admit that you would change anything that Nelson Mandela says. We did make one tweak. That used to say that the talk, and we modified it with acknowledgement and changed it to communicate. So without language, one cannot communicate with people and understand them. One cannot share their hopes and aspirations, grasp their history, and appreciate their poetry or savor their songs. And I say, as we think about cultural and linguistic competence and overall, and specifically looking at linguistic competence, that this is such a key and really beautiful way of looking at language and language expression. Next slide, please. So as we look at person-centered thinking, and again, looking at cultural linguistic competence overall, it's not just about providing interpretation and translation services. Culture and language are inextricably linked. Culture is encoded in language, and how we express ourselves, the way words are used, and again, our preferences. So as we look at person-centered thinking, language is just an essential aspect of how a person communicates, what they prefer and what they need. So if we look at person-centered planning, again, and this is as defined by NCAPS, and we look at the application of linguistic competence, is having the knowledge and skills to address all forms of communication in the planning process, and revisiting and revising the tools that we have now and approaches do not address the language culture link. So again, key and critical. And lastly, person-centered practice. It is ensuring that linguistic competence and language access are defined, that they're embedded in organizational policy, practice, and that fiscal resources, funds are there and allocated. So again, as we look at how cultural competence is linked to person-centered thinking, planning, and practice, as we look at linguistic competence, it is extremely linked, and that they have to be together. We can't look at them separate because they're part and parcel of who we are as individuals. Next slide. This is a resource slide for you. Gives you the data sources that we talked about earlier. And I think this, there's the next slide. I think that's it. Yes, summary slide. So many of the resources you can find on our website, and I am sharing this as I guess a precursor to really hear what my esteemed colleagues and panelists are going to tell you about their own experiences looking at linguistic competence. So I will stop, and if there are questions, we'll look at those later in the webinar. Thank you.
Thank you, Tawara, and hello to everyone. I think you've kicked it off just fantastically for the rest of us. My portion will concentrate, as you can see here, really on mental health, as well as substance use, mental illness, and intellectual developmental disabilities as well. So I'd like you to be thinking about those interactions, those services, those settings as we go through the context of my talk here. Next slide, please. So I wanted to talk a little bit about context, because context is extremely important of what we're talking about here today. And so the state of mental health in the United States, for those of us that have really are in the field, but I think even now the general population and around the world recognize the importance of mental health, substance use, and IDD, and how it really impacts us all. And as you can see there, 1 in 4 US adults experiences diagnosis with mental illness in any 1 year. And of those, 6% are dealing with a severe mental illness, which is to say like bipolar disorder, something like schizophrenia, or major depressive disorders. Our children are not immune. 20% of our kiddos are also dealing with mental health disorders. And as you can tell, mental health, in fact, starts actually quite early. And it's an opportunity of actually for prevention and hopefully to address these issues early on. But we have to have a system that is ready to do that. And unfortunately, in the United States, we don't have a system that's ready. It's fragmented and woefully underfunded. Half of all lifetime cases by the age of 14, and as you can see there, 3/4 by the age of 24. Many of us that are dealing with mental health issues, substance use issues, or intellectual developmental disabilities are remaining untreated or even unrecognized. And unfortunately, many folks that are dealing with these kind of issues are ending up in inappropriate places. One of them one of the places is unfortunately our judicial system, and we are folks with mental illness and substance use are overly represented in incarcerated settings, where in fact, you've probably heard it in the news, too many of our major jails around the country are now considered to be the major providers of mental health and substance use. Cook County Jail, Harris County Jail, LA County Jail, and the list goes on. And that is extremely unfortunate. Also, as you can see, because folks, we have an issue here with access, and I'm from the state of Texas, and we're one of the biggest, unfortunately, who have the largest population of uninsured, because we did not expand Medicaid, and there are other many states that fall in that category, especially in the South and Southwest. Well, what happens when folks are having to deal with mental health issues and they don't have access, they don't have insurance? Well, usually they wait until it becomes a crisis and you end up in the emergency room. So that's another area where we have an overrepresentation of dealing with our mental health issues instead of in ambulatory settings or going to see a primary care doctor instead. And it's a very costly way to deliver care. Next slide, please. Well, I've been making the argument for a while that we've been in a mental health crisis, and this is way before COVID-19. And COVID-19, if anything, has done is a great revealer. It's an unmasker, and it has really shown how really horrible our system of care really is in the United States. Sorry to say that, but that is, to me, my opinion and the truth of why we're trying to, in fact, improve the care for all individuals. But I've been talking a little bit about, morbidity, but mortality is death, and mortality is an outcome. And as you can see, the trend in suicides in the United States has been increasing since 1999. As you can see there in bullet 3, 30% increase in 25 states since 1999. And then there's the terrible numbers there. And these are the latest data from the CDC report that we have. More than 45,000 suicides annually. That's 123 per day. That's more than 5 per hour. And during our talk, more than 10 or 11 folks will have committed suicide here in the United States. And it's starting to affect across the board. As you can see, their second leading cause of death for 15 to 34-year-olds, and the fourth leading cause of death for 15 to 64-year-olds. And our veterans who have protected our country against external insults of all kinds are also suffering. As you can see there, depending on how it's defined, 17 to 22 veterans a day are committing suicide. Next slide, please. So let me switch a little bit to, that's contextualizing what we're dealing with. But let's also look at some significant factors for mental health and substance use. So one of the ones that is very important is the acceptability and the use of mental health and substance use services is highly governed by each and every one of us who we are, which means it's our cultural attitudes, our cultural beliefs, and our practices. And especially in the mental health setting, for social workers, for psychologists, psychiatric nurses, psychiatrists, we know and we understand that we're really talking about human behavior and truly understanding that. And in our way of dealing with that, because we are human beings and we are social beings, it's about collaborating and participating to be able to address the issues that could affect any one of us at any point in time. Unfortunately, the current science base around psychiatric diagnosis and treatment for way too long has only been about or involved our European origin populations. However, what is so important to know is that, as has already been laid out by Tawara, the diversity of the United States is so important, but our research still lags behind. There is progress being made to try to change that, to ensure that we're actually including non-European origin populations in our research and our studies, because we need to be able to really understand what is the best and evidence-based way to treat mental health, substance use, and intellectual and developmental disability issues. Well, what that ends up meaning is, because we're not quite there yet, right, is that minority populations face increasing challenges around mental illness and substance use. They're ending up in lower access to services, lower use of evidence-based treatments, higher burdens of morbidity because of that, which is the illnesses itself. And unfortunately, there's a lot of social determinants that really impact that. One of the determinants is, of course, access to insurance. So that really impacts how we're able to access services, as well as the lived environment. Do you live in a safe place? What happens also in the context of maybe food deserts? And the list goes on. All of those impact us as human beings, and therefore also impacts that not only physically, but also our mental health. Next slide, please. So let me drill down a little bit more for racial and ethnic minorities. So many racial and ethnic minorities are very wary of accessing care. And why is that the case? Well, a lot of it has to do with history, and as well as with prior personal experiences. Everything from misdiagnosis to inadequate treatment, and also, as has been highlighted so far, and that you will see, and probably you are aware of as well, is the lack of cultural understanding of community and individuals coming from racial and ethnic minority groups. We have a tendency to rely on family and religious and social communities a bit more than the average non-Hispanic white population. And that emotional support, though, is very key. And so often it is not found in our healthcare professionals. So we're more likely to seek help, not in the allopathic setting, but instead going through other specialty. We don't use specialty care because of that as well. Somatization is where actually, a physical, psychological stresses or illnesses do manifest themselves physically. And we've done a lot of great research now that shows the mind and body connection, right? And that it happens to everyone, but there is a higher percentage and a higher somatization that occurs in minority and racial groups. And it's important to understand that. As an example, systemic lupus erythematosus is an autoimmune disorder that unfortunately affects way too many at a higher rate African-American women. But one of the actual components of how it manifests itself initially is actually from psychological stress, either dealing with depression or even showing up as cognitive issues that indicates that, or it seems to indicate that there may be some kind of cognitive problems going on way before the other autoimmune physical ailments present themselves. And so we're not aware of that, then we have a tendency to unfortunately recommend someone to go to say a primary care physician recommends the individual African-American woman in this case, as an example with SLE, to first actually go to psychology or to social work, instead of in fact understanding there could be a component here that needs to be addressed to do the appropriate medical testing, because the sooner you can intervene with a disorder such as an autoimmune disorder, the better the outcome overall for individuals. And here's another one that's kind of a kicker. It's unfortunately salt to the wound, which is access is a big problem. We're not even getting there. A lot of untreated, unrecognized mental illness happening in this country. But then when you do actually, especially for racial and ethnic minorities, access to services, unfortunately, the quality is poorer than it is compared to the non-Hispanic white population. Next slide, please. And so and let me also emphasize actually for children as well, and the impact that it's having on our kids, especially kids, our children of color. The underprovision of mental health care for minority children actually ends up, unfortunately, in punitive sanctions because it's all seen as behavioral in the sense of that this is a failing of their moral standards, or they're just not behaving appropriately, instead of recognizing and understanding that mental illness is an illness just like any other and needs to be addressed. And hence, what is the outcome? Excessive rates of school discipline with suspension and expulsions, and it starts at a very early age, even including, unfortunately, preschool children, especially African-American boys, being targeted and seen as behavioral problems instead of recognizing what they may actually be dealing with, like attention deficit disorder or some other type of illness that affects kiddos at that age group. And minority teens disproportionately, unfortunately, are recognized and seen in the juvenile justice system with higher rates of arrest for nonviolent, low-level offenses. This has long-standing consequences, especially for those that understand ACEs, the adverse childhood experiences, and the impact that it has throughout one's entire lifetime, and the sequelae that comes with that. The diversity of the mental health workforce. I've talked about a bit of the underfunding. It's fragmented. We really, in fact, don't have a mental health system in the United States because we often say the mental health system is broken. Well, I would contend and say that, in fact, it's not broken because you'd have to have something that was working well and appropriately to break. We've never just actually achieved that. What's had is just we have hotspots that, as well as areas that are doing well, but it's not cohesive, and definitely there's never been a strategic approach, which is very unfortunate. But you also have to have the appropriate workforce to be working in mental health, and also working with all the different diversity of humanity that lives within the United States. And we don't have that either. We have very poor representation within our groups, as you can see here in psychiatry and psychology for African Americans and for Latinx. It's woefully underrepresented. But it's not just about the numbers. There is the numbers game that is very important, but it's also the quality of and the skill set that our providers need to have. It is also equally important, because when it comes to cultural linguistic competency and being person-centered, it's really important to be multicultural and multilingual, or bicultural and bilingual, whatever the case may be, and not actually just have the language skills, because that's very different. And then we also know that, in fact, within language skills, it is also important to be able to communicate in the language of the profession itself. You know, what we use in psychiatry and in psychology and in social work, the terminology is very different than what is being used, like, say, by your OB-GYN doctor, as an example. And so even within the professions, we often don't even understand ourselves if we drop into and use the med speak that is consistent or specific for our one area. And unfortunately, and Tara did mention this, is stigma and how mental illness and substance use and even intellectual and developmental disabilities is misunderstood. It is influenced by everything we've been talking about so far, but it is a very important component also that we have to contend with, not only across the board, but even within our cultural groups, the stigma that resides there in trying to address these very issues that, to me, are no different than any kind of physical ailment. Next slide, please. Well, what are the consequences of not understanding culture and language when it comes to mental health and substance use and IDD? Well, it can be very, very concerning. And as I mentioned, it also results in why cultural groups or individuals do not access services even when they're available. But what happens is really these misunderstandings between us as human beings. And it results in lack of therapeutic alliance, poor adherence to treatment plans. And of course, the most important one, because of all those they build upon each other, is really poor clinical outcomes. Because those of us that are in the medical profession, those of us in the healthcare professions, we all do enter with I think, really good hearts wanting to help our fellow man. And yet we're falling short. And that's why we're having these kind of talks to understand why are we falling short and what can we do to in fact make the outcomes better for all. It also contributes to racial and ethnic disparities, especially in mental health and substance use when it comes to access, availability, and as I've mentioned, once you even utilize services, they may be not appropriate as they should be compared to the non-Hispanic white use of the services themselves. Next slide. So let me give you a classic case of what can happen when things go awry. The case of Rita Quintero. Many of you may know already about her because it's a very well-known case. But in 1983, she was found wandering in a street in a small Kansas town, oddly dressed. She seems to have not bathed recently, according to the accounts at the time, not able to communicate except for a few Spanish words. What ended up happening? Well, unfortunately, she was involuntarily committed, and she was determined to be mentally ill. And they also assumed that she was Spanish. A patient advocacy group, though, that had been working with the state mental health institution where she was being held, was working with other patients, and they took an interest in Rita, and they are the ones that learned that, in fact, she was a citizen of Mexico, but she was not a native Spanish speaker. She, in fact, was a member of the Tarahumara Indian tribe of Mexico. And it turned out, and they brought to the attention of the institution and the caretakers there at the mental health facility, that her appearance, her dress, her behaviors were all traditional aspects of her culture. And in fact, when they finally found someone who was a native speaker of Ramuri, which is the tribal language for the Tarahumara Indians, she could communicate with them just fine. She was not a native Spanish speaker, as one key thing. They were making assumptions here. And so after the interpreter was located, she was released because she was found to be competent, did not need to, no longer was determined to have a mental illness, and she was able to return to Mexico. And the year was 1995. Notice, that was 12 years later though. And also think about the implications when it comes to not being able to communicate with her, that they were medicating her during this whole time as well. So were they able to get consent? I think not. And there are other major issues that this case brought forth. Next slide, please. But you know, if we do this well, and if we do it right, and if we implement it as we ought to, which is to be really culturally linguistically centered when it comes to mental health and substance use care, and of course in the bigger context, really just health in general, and to address health equity, we know that we can make a positive impact. Why? Because approaching it as a person-centered and culturally linguistically centered, we're responding to current and projected demographic needs of across the United States. We can address disparities and the health status for people, regardless of their racial and ethnic source. Also, socioeconomic status is very important. Do you live in an urban or a metro or a rural area? And of course, all the different types of cultural backgrounds that are coming to play here in the United States. I also believe that it will help. It does help against the quaternary aim. Many of you have heard of the triple aim. which is about improving qualities of services, the outcomes, and of course the patient experience. But I would add also important to that is actually the engagement that needs to happen among us and between us. Hence the quaternary aim, I think. So continue to diminish and eliminate the stigma associated with mental illness and substance use disorders would happen if we're able to have a culturally linguistically centered healthcare system. Next slide, please. So Colorado presented the national CLAS standards, and what they are also very important because it's a mapping of framework to address health equity also within community and state mental health agencies and even our ambulatory settings, because it would help us to address the disparities that we're dealing with there. Everything from low patient literacy, clinician biases, to also unequal geographic distribution of mental health and substance use resources. Next slide, please. But here's the rub. What is the status of the national CLAS standards currently in public mental health agencies? A recent nationwide policy analysis was done, released a couple of years ago, and only 8 states have adopted all of the national CLAS standards, the ones that Tawara went through with you. And actually there are 10 states that have no policies, no implementation at all, or adoption of the national CLAS standards. And then you can see the rest. There's a few that fall that only have accepted 1 domain, 5, 3 that accepted 2. Now, the positive thing is the large majority, 25 states have, though, implemented not all of the CLAS standards, adopted them all, but they have adopted some with all the 3 domains. And so this is an area where, from a policy standpoint, but also from a practical standpoint, that many of you can actually hopefully ask and ensure what's happening here, not only at your institution, at your setting, but also at your state, and especially at your mental health agencies. Next slide. And here are the references that you can look up. All of these I made reference to. And I'll turn it back over to Tawara. Thank you.
So I think who's next up is Janira, if I'm not mistaken.
I'm here. Can you hear me?
Just a little louder, please.
Hi, this is Yanira. Can you hear me okay?
Yep, we can hear you.
All right. Well, thank you, Alex, Tawara, and it's great to connect here with Octavio and Matt. So I'm Yanira Cruz. I'm with the National Hispanic Council on Aging. And I'd like to start by sharing with you a recent experience I had with a person who is a psychiatric patient who is bipolar and who speaks only Portuguese. He speaks a little bit of Spanish, but not fluent enough to communicate. So I came across this person and helped him navigate the healthcare system in Montgomery County, Maryland. The only psychiatrist that was available at the time to help him only spoke English. So this person was in great need of help. He was going through one of these crises, and fortunately, the psychiatrist was able to provide her services and communicate with the patient in Portuguese through a translator that she arranged for during the visit. So without this translation service, this person would have been in danger for himself, but also he would have placed possibly others in danger. So I shared this experience with you because it's one that I recently went through with this person, and it reminded me of the importance of having access to the language that the patient understands, that is comfortable with, especially when it comes to medical issues. So I so much appreciate the protections that we have in place to give access to persons for services in their language. But I should add that unfortunately, just last week, I was in conversations with the Office of Management and Budget, the National Hispanic Council on Aging, along with other organizations that advocate on behalf of vulnerable populations and immigrants, had to have a conversation with OMB because they are proposing eliminating the language access protections as proposed in the non-discrimination in health education programs and activities out of the Office of Civil Rights. So I have to say we need to be vigilant, and we need to monitor those protections that we have enjoyed all these years, but are now under threat. Do know that, though, that there are organizations advocating and on behalf of protecting this law. And the Justice in Aging, you may know of them. They are taking the lead in this effort. So with that, I want to continue with my presentation here and share with you some of the realities of the population we serve, primarily Latinos, though we sometimes serve other diverse populations. But most of our population, or many of, I should say, are monolingual in Spanish and don't speak English. A significant percentage are illiterate in their native language. The health literacy level is low. Many of our populations that we serve live in mixed families with multiple generations where one or more persons are undocumented, keeping them from accessing services out of fear. And you will recall that in the last 12 months, the issue of public charge came up. And with that public charge, many families and individuals have decided not to access services out of fear of having negative consequences with their immigration status. We also face a digital divide. So the population that we work with has challenges accessing technology, either because they don't know how to use it, and sometimes because it is not available. So conversations like this one, for example, like Zoom calls and webinars, oftentimes are very difficult to bring to our populations because they just don't have access to it. And COVID-19, the pandemic, has made more visible the inequities that have existed for a long time in our community. And so we've had to get creative during this pandemic to communicate with our population. We know, for example, that Facebook is very popular, and we are starting to create groups in Facebook to connect with our population. Of course, we're also doing teletown halls and communicating through social media, and that is fulfilling a gap. Also, older adults, Hispanic older adults, often don't have access to technology as well. And for older adults, this problem is even more complicated. They don't know how to connect, and right now with telemedicine being such an important vehicle to stay connected with the healthcare system, not having this technology and knowing how to use it becomes a huge barrier for our population. So what are we doing as an organization to offer cultural competence and linguistic appropriate services? So we are producing our programs, our materials, and outreach in English as well as in Spanish. And some of the information is also developed in Portuguese. For example, recently we had a teletown hall on the coronavirus. One teletown hall was in Spanish and the other one was fully in English. And we are experiencing good results with having events or programs that are solely in the language that the person prefers. As far as reading level, our programs are targeting local communities using a 4th grade reading level, and that seems to be working. The health literacy level for the entire nation, as we heard earlier from Tawara, is very low. And for the population we serve, this is especially true. The other element is familismo. Family is an important element for Latinos and for other diverse populations. So we design programs keeping in mind the family where appropriate. For example, we have done some work in the area of diabetes management, and we know that there's better diabetes control among those individuals who have a supportive system from their families at home. There's also institutional trust. And so there are particular institutions that are trusted by our community, by the Latinx community. So medical doctors are trusted, priests, the church. Radio and television are also important mechanisms to disseminate information. I think the important thing is to meet the population where they are in the language that is preferred by them. So soccer games, for example, are important gatherings. Again, churches, looking at ethnic newspapers, and of course, local clinics and community-based organizations that are trusted by our communities. And last, I wanted to just mention the CLAS standards that were developed by the Office of Minority Health out of the Department of Health and Human Services, which are important protections that we have and that we should get familiar with to use as we carry out our programs, you know, whether it's in the nonprofit sector or in government or at the local or national level. But those standards are an important foundation that can help us be intentional about delivering services and programs that effectively serve populations across the spectrum with appropriate language and cultural competency.
Thank you, Yanira. This is Alex Bernardi, and I just wanted to step in and say thank you. I'm mindful of the time and just wanted to see if you had a final word, or we can move on to Matt and be sure that he's got time. Just a word for our all the folks who are on this webinar. We are collecting questions in the chat function. We probably won't have time for Q&A with our speakers, but we tend to have opportunities for them to review your questions, and we'll post responses online. Thank you, Yanira, and I'd like to turn it over now to Matt McCullough.
So good afternoon, everyone. Thank you for staying all the way through. And so I want to thank Miss Good for inviting me. So Tawara has been the greatest mentor in terms of cultural and linguistic competence, and so I've known her for several years, so thank her for inviting me. So all three presenters have talked about linguistic competence. I'm going to focus on the foundations and principles of person-centered practices and systems as it relates to linguistic competence. Next slide. Next slide. So I'm going to primarily focus on the concepts and mandates with the context of service providers' roles and responsibilities in serving people, primarily in the display world, dealing with seniors and so forth. Next slide. So just realize that I am a person-centered trainer in DC. I belong to the learning community for person-centered practices. And so our sole purpose is to empower people with disabilities to take control of their own lives. However, as all of you know, that when people with disabilities start interacting with government services, they may lose a sense of independence and self-worth, and so that's what the learning community is all about. Next slide. And next slide. Thank you. So to cover some of the, so what's person-centered thinking? Well, it's basically the ability to respectfully listen, and which allows people to have more positive control over their lives in terms of what they desire and satisfy. We serve to recognize that all people with and without disabilities have contributions that they offer within their communities, and not only that, that the critical parts of what person-centered thinking is all about is trying to identify those web of relationships, both natural and paid, within the neighborhoods and communities. Next slide. So what are the person-centered thinking skills that are necessary? This lends to linguistic competency. You should be able to communicate the learning cycle in terms of, we should be supporting people overcome effects. It's very hard to understand how to start probably supporting people. We are always in that mindset of trying to fixing, and that's how we come across in our overall communication. Just realize that this process works for any person, not just people with disabilities. It also is impactful on businesses and systems, and that's what to our focus on the CLAS standards. Just understanding that you gain some wisdom between understanding culture, terms of learning, partnership, and accountability. And once again, person-centered thinking is the belief that everybody can learn. Next slide. So in terms of the disability community, we are constantly identified in terms of a service life where many folks with disabilities, seniors, primarily get most of their services from the government systems. And so it's been, over the past several decades, there's been a shift from the service life of having people placed in institutions and start having good transitions out into the community. And so you start getting a good PLAI, which means that there's a mixture of government services supporting along with this natural support. However, our ideal outcome in terms of people with disabilities and seniors, to have them remain in the community as long as they can with the appropriate mental supports possible. Next slide. So in order for people to remain in the community as long as possible, we must communicate and critical choices along our life trajectory, starting from birth all the way to the end of life. And all these phases are constantly intersecting with each other. Next slide. So these decisions that you form for yourself and the family starts to impact the way you interact with other people. And all these questions that you see on the screen are basically, how do you integrate your own cultural and linguistic competence in terms of how you interact with other people? So for example, for some of you may expect people to start eating before you do, and you would need to say something that indicates how you would want to operate at the dinner table and stuff like that. Next slide. All right, so when it comes to cultural and linguistic competence, all these elements that you see on the screen, practices, rituals, manners of interacting, courtesy, these are all ways that people observe, and the way that they observe is through their understanding. And in terms of working with families, you need to instill some great level of competency in terms of your linguistic competencies of how you see the world around you and how do you improve the quality of life of the folks that you're serving. Next slide. So this slide is coming directly from the National Center for Cultural Competency. That when it comes to linguistic competency, it basically, in terms of culture, it basically determines what's right and wrong, what's good and bad, and how things should be. And so when it comes to linguistic competence, in that box on the left, it talks about culture can be revealed in comments like, "This is not right." How do we do things while men and women don't do, and so forth. So the thing that you need to understand is that you need to be aware of cultural assumptions. This is critical because if you were born and raised in the United States, you're constantly taught to be independent from one another. However, if you were raised traditionally in other countries, the family structure is critical. And so in order to do this type of work of person-centered practices and thinking, you need to have a shift in that not everybody totally understands what it means to be independent, that independence is part of the family structure, and you can't operate without that support within the family. So just realize that. Next slide. So what's the core concepts of person-centered principles? I know that this may be very simple and basic, but it's absolutely true. The core principles for person-centered attitude is understanding the importance to what is to that person and what's important for that person, and finding the balance between the two of those core principles. Next slide. So what's important to? So basically, what makes that person satisfied, content, confident, and be happy? This is based on your understanding of, in terms of confidence, what people are currently in their lives, what gives them the status of control, what do they do within the community, and how do they contribute. You need to understand rituals and routines and rhythm of peace of life. For example, New York City, constantly on the go, but if you go to rural Texas, peace of life is much less, and that really matters to how people should be interacting with each other and so forth. And things to do. Next slide.
And Matt, just one I just want to note that we are at the end of time, but this webinar is being recorded, and Matt, we'll let you go ahead and continue on. If you are able to stay for just a few more minutes, you'll get to hear the end of Matt's presentation, and we'll do a couple of evaluation questions.
So yeah, most of it, and I will try to move very quickly through these slides. Just realize that the important too is allowing the person to define their own quality of life through their words and through their behavior. Next slide. So, but what we are constantly identified with and more familiar with is what's important for that person with a disability or senior citizen. We are constantly aligned with understanding the health, safety, and safety factors, and so understand that in terms of the health and human services role, we are very familiar with what's important for people with disabilities and seniors. Next slide. And so it's very critical to understand the overall connections between what's important to and what's important for that person. And simply because I'm going to quickly move forward. Next slide. Because if you don't understand the balance between what's important to you and what's important for, you have all choice what's important to you, but there's no responsibility for all those folks that have teenagers. This is what they're trying to do. They want all choice, but they don't want any other responsibility. So parents with teenagers, you totally get this slide. Next slide. So folks that work in the health and human services industry, you identify safety and what's important for that person. And in many cases, many states, it dictates the lifestyle of what that person is taking. Next slide. So it's a constant negotiation of using linguistic competency on how to communicate to a family of finding that balance of understanding limitations and impact and trying to have that person embrace what options do they have and what's driving them to make those choices. Next slide. So here's the ideal outcome in the person-centered systems and practices. You're constantly seeking that balance. Next slide. So why is choice and balance so important? Well, I'm really focused on this purposely, that if you have all choice, there tends to be real consequences of not understanding the responsibility incurred in those activities and of course when the lifestyle is not being allowed to interact with what's important for, that the person may be alive, but they may be super miserable. So finding that balance is a constant negotiation. It creates conflict because it forces the service, health and human services providers to understand and truly understand what that person is all about. And in terms of our role, we need to start letting go and allowing people with disabilities and seniors to make their own choices, even bad choices. Next slide. So in terms of the linguistic competence role, we have a history, a horrible history of using our words to dictate and to use power over people that are receiving our services, the critical part is that in order to practice good linguistic competence and cultural competence, it's all about sharing that power between the person that we're serving with them. All right, so next slide. So a lot of questions that lend to supporting rather than fixing lends to the linguistic competence that you can exhibit. For example, understanding how do you communicate with people, and how do you help them achieve success, what's important to them and what's important for them, and it's constantly understanding what's not working for them, and understanding that there are ways to help them understand to improve their quality of life. How do we get to point A to point B to point C? And it all basically coming down to understanding that wisdom of how do we constantly engage with our citizens with disabilities going forward. Next slide. Because if we don't practice solid cultural linguistic competence, in many cases we are constantly stuck in the two sectors of what we are very familiar with, that in the health and human services arena, people with disabilities and seniors really. However, if you practice good linguistic competence and truly understanding where do those types, you need to understand that in terms of good linguistic and cultural competences, it's all about being supportive and healing, and that leads to sharing the power with that person receiving the services. And that's what person-centered practices and systems should look like, that we are constantly trying to get to the supportive and healing sectors of this graphic. Next slide. It's about giving people better lives, and working for government systems, we are constantly bogged down with paper, but at the end of the day, paper doesn't matter. People's lives matter, and so at the end, we are charged with making their lives better. And so with that in mind, I thank all of you for listening to me in terms of this particular presentation, and my information is included in the slides as well. Thank you very much.
Thank you so much, Matthew, Octavio, Yanira, Tawara, for this rich information. It's a testament to how fantastic your presentation is, that more than half, way more than half of folks have stayed on a full 10 minutes after to hear your words. So thanks everybody for staying as well. Just a quick couple of words before we hop off and go to the rest of our afternoons. Please join us for our June webinar, which will be focused on successful stakeholder engagement. We're super excited to have this panel of folks coming and speaking to you. You can register for that webinar on ncaps.acl.org. Next slide, please, Connor. Please do, if you have a moment, take a quick second to answer these evaluation questions. I think there's just a handful, and we'll put these up for you. Let us know how we did, how we can improve. We're always looking to improve. And we'll leave these up as people take off. Once again, the recording will be available to you on our website, ncaps.acl.org. gov in a couple of weeks, and these slides will also be posted. I know many of you are hungry for them, and we will get them out to you. Oh, cue the child. Okay, so happy Wednesday, everyone, and we wish you well. See you in June.